Okay, thank you everyone for joining us for Mini Grand Rounds. Today we have Aaron Friedberg here to talk to us about an update on influenza. Thanks, Aaron.
All right, thanks, Jared. All right, well, I just wanted to talk a bit about flu in terms of all the pieces, parts of what we do with it, the infection itself, and how to manage it and how to prevent it. And so just kind of give a run through of the current state of affairs with that. In terms of objectives for today, we want to know the clinical manifestations of influenza, what to look for, how to diagnose it, how to treat it, and how to prevent it. So we'll go through that and try to meet all those goals. So first, I'd like to give you a few case examples of people that we'll try to figure out what to do about, and then we'll come back at the end and talk about them. So one is a 35-year-old African-American female who comes for preventive care, a 45-year-old white male with morbid obesity and asthma who's coming in with 72 hours of fever, cough, and fatigue during an outbreak, a 67-year-old male Alaskan native who comes in for preventive care but has mild fever and sinus congestion for a couple days, and then a 20-year-old Bhutanese pregnant woman in her 14th week of pregnancy who comes in for a routine visit. So think about those folks. So background, influenza, so it's an orthomyxovirus, and it basically comes in two varieties, A and B, and you get these outbreaks and epidemics generally in winter season, and usually it's a self-limited respiratory illness with systemic symptoms. It's transmitted through large particles, so the masks are good for this, greater than 5 microns, basically about a 6-foot range, so if you stay more than 6 feet away from your patients, you're probably okay. There's some question about could it be transmitted other ways, maybe through the eye. There was one study where they tried to show that rather than respiratory directly. And then, small particles do carry the virus, but they haven't shown that they actually matter for transmission. It is there, but it doesn't actually seem to transmit illness much. So as far as incubation, it can be anywhere 1 to 4 days. 2 is about the average, and the serial interval, I'm making air quotes here, so the time between onset of illness among household contacts is about 3 to 4 days. So if your family member gets it 1 day later, probably didn't get it from them. They get it 2 weeks later, probably not either. As far as viral shedding, so you can pick it up between 24 and 48 hours, but at low levels, and then about from exposure, and then it really starts to pick up in the half day to day before you start having symptoms. It peaks at about a day or two, and it starts to drop off. The average total shedding is about 5 days. Most viral shedding is gone by day 6, but it can last up to day 10, and really it can stick around much longer in folks that are immunocompromised and have chronic lung disease or diabetes up to almost 2 or 3 weeks. You do shorten that shedding interval with Tamiflu, and the severity of symptoms does appear to correlate with the amount of shedding. And this I thought was interesting is it's not like everyone has the flu is evenly distributed in terms of who's spreading it. The top 20% of infectious adults account for more than 3/4 of the flu cases. So there are a few out there who are those bad ones, and they're the ones you need to avoid. And it does seem like probably the people who are sicker are among those. As far as symptoms, so acute fever, 100 to 104, headache, muscle aches, malaise, respiratory tract symptoms, non-productive cough, sore throat, nasal discharge, and they talk about being an abrupt onset. I remember the minute it happened, but not always. And in older patients, it can be a little less specific, but it might just be not eating well, feeling weak or dizzy. GI symptoms, not as common in adults, it's more seen in children. And then physical findings, it might be hot or flushed or have some oropharyngeal hyperemia, but it's not terribly remarkable in a physical sense. The labs aren't that helpful. If they have a high white count, they probably have something else going on, like a secondary bacterial infection. As far as complications, so who is at high risk? This is a key group you need to remember for later, too, in terms of treatment and such. So the extremes of age, less than 5 and greater than 65, obviously, other than that piece, focusing on the latter part of that. And then pregnant and up to 2 weeks postpartum. You give the vaccine at any stage of pregnancy. Immunocompromised folks, can't give them the live vaccine, and it's a little unclear if the high-dose vaccine is necessarily more helpful than the regular one. They've done some studies, and that's like an HIV, but not necessarily. And then some chronic diseases, so asthma, COPD, cystic fibrosis, everything cardiovascular except hypertension, renal, hepatic, hematologic, endocrine, neurologic, developmental delays, spinal cord injury. So a lot of chronic diseases are putting you at higher risk of complications. Children and adolescents on aspirin long-term, Native Americans or Alaskan Natives, if they're obese and their BMI is greater than 40, and nursing home and chronic care facility residents. These are the more vulnerable people. In terms of what you can get, there is a primary viral pneumonia. It's more rare, but you can get it and can be severe. There's also a secondary bacterial pneumonia that's more common. We worry about this particularly in our 65 and up set. The main thing to watch out for there is the double dip, where they get better than worse, then you're worried about a secondary bacterial infection. And it's probably contributed to by loss of cilia that you get with the flu infection, and also having increased sites of attachment, again, probably stimulated by the flu virus. In terms of organisms, so about half of it is strep pneumoniae, and another 20% or so is Staph aureus, and you can even get toxic shock syndrome in certain cases. You can get myositis or rhabdomyolysis, again, more in children, but you can get it too. And then you can actually get probably a primary cardiac issue. There's an increased risk of MI in the first few days, especially in folks over the age of 80. And there is this myocarditis that in most fatal cases, I think it was like 20 out of 26 fatal cases in one study, they had myocarditis. So if they die of it, they're likely to have this problem. So how do you diagnose it clinically? Fever and cough. Those are the big ones. Both retrospective and prospective trials show these are the best signs, and especially if you're during an outbreak, they're the ones that are going to be right. In sporadic cases where there's not an outbreak, only about 10% of the cases can be flu, so it may not be as helpful. For patients 60 and older, maybe less specific, but fever, malaise, and chills were the best indicators in studies. Sneezing actually made it less likely. So I talked about flu, nothing to sneeze at, as a play on words, because sneezing makes it less likely. But none of these are perfect indicators. So as far as the testing options, so there's rapid testing, and a lot of the studies on the effectiveness and use of rapid testing were based on the older tests. The newer one that we're all using now is much better, and so probably we could use it differently, but the recommendations haven't quite matched up with that in terms of using confirmatory tests. But probably our screening test is a lot better than the trials that were done with the other ones. But basically, on the older tests, they at least said that if the probability of having flu is about 42%, the benefit's about even of testing versus just going ahead and treating them. There's also immunofluorescence, which is not quite as good as culture, but you can get in hours. RT-PCR is the gold standard other than the viral culture, and the best thing about it is you can get it in 4 to 6 hours, but the lab itself may take longer to get it. So it doesn't take long to do, but it depends on where you're doing it. But that one, you can get all the subtypes, the most sensitive, specific, but you can't get it right away. And then the Alert one, that's what we have. This one's fast. It's very accurate, 90% sensitive and specific. So obviously we're using that a lot now. Viral culture takes, of course, 1 to 3 days, and you really can't use it for clinical decision-making. And serologic testing is more for retrospective testing or research. Basically, you have to test them during the infection and then afterward and see if there's a 4-fold rise. But on a practical level, we're not using this much in clinic. So who do you test? So people who are immunocompetent, who are at high risk for complications, that set of folks we talked about before, within 5 days. Immunocompromised folks who have an acute febrile respiratory illness at any time, even beyond that period. Fever and respiratory symptoms after a hospital admission, anytime. And then healthcare workers, residents, visitors in an outbreak who have the same. And then if there's an epidemiologic link to an outbreak, so, close contact family member, and basically once you have the activity, you can treat based on the symptoms. So which test to use? Really, the RT-PCR is the best, according to what they're saying, but on a practical level, we're going to be using the screening test first, but they do recommend in certain circumstances using the RT-PCR to confirm, basically, if you have a negative test, but you really think it's likely to have it, high community activity, positive test for not many people in the community are having it, you think it might be a false positive, or if there's a recent pig or poultry exposure, because the immediate test, it gives you AB, but it doesn't give you any of the subtypes. So if you want to see if it's something new, like this H3N2B, I don't know, this woman in Ohio who died because she was around pigs, this is the sort of thing that you use to test for that. And then viral culture and serologic testing, the same thing. These are more for population and epidemiologic testing. So what can you do for this? So these are handy diagrams from UpToDate about basically, let's say you're in an outbreak and you're doing rapid testing. So let's say your test is positive and you get flu A or B. You're saying it's probably flu, you should probably go ahead and treat it. You can consider doing a confirmatory test. Really, it's more for if you want to see exactly what it is, more for epidemiologic purposes. Let's say flu is prevalent, but your testing is negative, but your clinical suspicion is high. You got to decide. If you think it's flu, you should go ahead and treat it in that circumstance. In contrast, if flu is rare, you're in the summer, or like now, there's really not an outbreak, even though we're starting to get in the winter months. Let's say your test is positive. It could be false positive. You have to kind of decide what you want to do. You could use a confirmatory test and go ahead and treat depending on what you think. But if it's negative, you can just say that's not it. You should never make any one test your only decision point, but probably you could say it's not flu. So how do you know which one to use? Well, there's this handy map that they have on the CDC website, and you can sort of zoom in and see what's happening locally for where are we right now. So this is the most recent, or these are the most recent set of data from last week, basically showing where are we. So Puerto Rico is looking pretty awful right now, but Ohio's looking pretty good. We're still in the, pretty minimal area in terms of flu. So we haven't really hit the season yet. Georgia's also kicking up there, but overall, we're not too far along in terms of the country. So keep an eye out for it, but it's not big yet. So in terms of treatment, two big classes. I think we're probably pretty familiar with this, but you basically have the neuraminidase inhibitors, so they're good against flu A and B, so that's, Tamiflu and, also zanamivir and peramivir, and the adamantanes, amantadine and rimantadine, but basically those have gotten incredible resistance, so we don't use them anymore. What's the benefit? Well, back when they worked, the amantadines did this, but now the neuraminidase inhibitors shorten the duration by a half to 3 days, depending on which study you look at. They do reduce the duration of viral shedding, and the best benefit is in the first day or so, or day and a half. Most of the trials on oseltamivir are limited to the first 48 hours, so it's not that it's ineffective, but it's most effective in that period. And it may reduce the complications of flu. Some studies showed that it did, pneumonia, death, et cetera, and some of them didn't show that, so it may or may not. As far as the indications, so if you have an illness requiring hospitalization, just go ahead and treat. If you have progressive, severe, complicated illness, go ahead and treat. High risk of complications, so all that set of folks we talked about, go ahead and treat. And in those populations, you don't worry about that 48-hour rule. If they're sick, you go ahead and give them the treatment if you're worried about it. So who doesn't need it? So mild illness, if you're not a high-risk person and you're under the age of 65, you can use it for symptom relief if you catch them in the first 48 hours, but you don't have to. And if it's outside the 48 hours, just don't treat it. If they're feeling sick, then that's a different story. It wouldn't be mild illness then. Really sick, I should say. So how do you treat? Basically, use oseltamivir, zanamivir, and use peramivir. Basically, they can't take inhaled oral meds. In terms of the dosing, so Tamiflu, it's just 75 twice a day for 5 days. You can consider doubling the dose for certain pandemics, so like if avian flu is going around or H1N1, but for regular seasonal flu, there's no need for that. And then you do adjust it for renal insufficiency, and it may be less effective for flu B. For Relenza, there's an zanamivir, so it's just 2 inhalations twice a day, no renal adjustment because it's not really systemically absorbed particularly, and just don't use it with asthma or chronic disease because it could flare things. For the Rapivab or peramivir, it's just a single dose. There were some studies that showed that 600 was maybe about the same as 300, but they say just go ahead and do 600. You also have to adjust that for renal insufficiency as well. And then also you want to treat fever, so acetaminophen or NSAIDs, just obviously avoid if they're under 18 and using aspirin. So for zanamivir, for all these rather, what do you need to watch out for? So for zanamivir, bronchospasm is the big one. That's why asthma and COPD are no-nos for this. And because it's like a powder kind of thing, you can't really use it in nebulizers or mechanical vents, so it's not an option there. For Tamiflu, so nausea and vomiting are the big ones. And there were these studies that showed this like self-injury delirium side effect. I don't know if you've heard about this one. It was really mainly these Japanese studies. I guess they use it a lot more often over there, and so they have more data on this. It was more in children, and then they did further studies on it, and they didn't really see it. So, this is not something that's considered a major issue, but it was reported in some studies from Japan. And then peramivir, nausea and vomiting, and you can get hypersensitivity reactions. So what about resistance? It already happened to one class of drugs. What about the neuraminidase inhibitors? So at least at this point, about 99% of isolates are still susceptible to oseltamivir. There was a set about 10 years ago of strains that were more resistant, but they kind of went away. The swine flu was fairly sensitive, and so we're still pretty good there. And then just in terms of alternate formulations, there is this compassionate use IV zanamivir version that you can get. The main benefit there is if you're concerned about resistance for some reason, perhaps there's another case that was resistant nearby, or you feel like it's not responding. One of the common mutations is this H274Y. And that one confers resistance to oseltamivir and peramivir, but not zanamivir. So if they can't take inhaled, that might be another option, probably more of a hospital thing there. And then as far as how long, so it's 5 days for oseltamivir and zanamivir, and you can certainly do it longer if they're really ill or immunocompromised, or if you keep doing an RT-PCR and they keep coming back positive, you can continue the treatment longer. Then it's just a single dose for peramivir. Then there's the special case of pregnancy. So what do you do with pregnant women? So they are category C. There just aren't a lot of good data about it. There have been no adverse events shown, but no one's really studied it well. Basically the consensus is if they meet case definition for influenza A, go ahead and treat. And that can be clinical criteria or it could be laboratory criteria plus clinical. But basically the benefits outweigh the risk, and they actually recommend using oseltamivir because zanamivir is not systemically absorbed. It's not going to protect the fetus. They actually prefer oseltamivir for that. And for those folks, it is okay to treat after 48 hours, especially if they're in the hospital. And you want to make sure to control fever with Tylenol, not NSAIDs if you can avoid it. It's particularly important in the first trimester to avoid neural tube defects. For infection control, basically, how long do you have to stay home until symptoms are better? The question is, what can you do for household contact? So they did a study where they looked at just having all household contacts where use good hand hygiene. They did this in various ways in a couple of studies. One was just showing them. There's another one where they had access to like an online hand washing training. They just did that plus face masks, and as long as they started within 26 hours, it actually did materially improve decrease the risk of household transmission. So there is benefit in trying to prevent household members from getting the infection. They may be less likely to get it. So vaccinations, this is a big one we're working on at this point, is who do you give it to and when? So at this point, it's, since 2010, then just recommended blanket for 6 months of age and older. They replaced older guidelines. And then vaccine production takes about 6 months, another 6 months there. They basically just do it based on the strains of the previous season, so sometimes they guess well and sometimes they don't. So what are the options out there? Basically, it's either trivalent or quadrivalent. What they generally do is do 2 strains of A and then either 1 strain of B or 2 strains of B. So, and the interesting thing is not all these are new every year. So like the A strain is actually the same one they had for the H1N1 in 2015. That's to protect against that 2009 swine flu. And then the second one is a new one for 2016. It's this H3N2. For B, there's this Brisbane misspelled there, like virus. Total, I think the B viruses, their minority is 26% of infections, but they do recommend doing the quadrivalent because among the B infections, almost half of them are this other, B virus, this Puka 2013-like virus. And so if you're only getting the trivalent, you're missing almost half the B strain. So you might as well get the quadrivalent if you can. What are we fighting? So antigenic shift and drift, just briefly. The drift is sort of usual annual epidemic, and they've never seen anything other than this in influenza B so far. The shift is when you get pandemic flu A. So as far as the available vaccines, so the one we're most dealing with is the standard dose, trivalent, quadrivalent. You can give it with a needle. There's also this air injector you can use in 18 to 64-year-olds, which appears to work okay, although it has perhaps some increased skin response reactions there. There's a high-dose trivalent. This is the 4 times dose for folks 65 and older. There's also this adjuvanted trivalent, the Fluad, which is for 65 and up, but the immunization recommendations from the government doesn't really endorse this yet. They just focus on the high dose. So it's out there, but they're not necessarily endorsing it yet. There's the intradermal low-dose quadrivalent. So this one's only for 18 to 64. It only uses 3 micrograms instead of 15, so it's a lower dose, and it uses a really tiny needle. So if you have someone, excuse me, who's really afraid of needles and doesn't want the big needle on the regular flu vaccine, this is an option. However, it does have increased skin reactions, so something to watch out for. There are a couple other options that they have for people who have potentially allergy issues. One is this one that's done in like cell culture, so it's the flu cell vax. This is for people over the age of 18. However, at a point in the process, it is passaged in eggs. So even though it's a culture cell vaccine, there still could be some evaluation present, although probably not very much. The other one is this recombinant DNA baculovirus expression trivalent. They're probably going to have a quadrivalent one next year, but it's not available for this season. That one is only the hemagglutinin antigens, and it's basically another egg-free option. There's also the quadrivalent, live attenuated virus vaccine, but it's not available this season because it wasn't that effective. So how do you choose? If they're 18 to 64, just do the standard dose, go for quadrivalent if you can. There's the intradermal or the air injector for people that are maybe needle phobic, but the intradermal is not okay for 65 plus. For the air injector, there may be a higher rate of site reaction, and live attenuated just isn't an option this season at least. For age 65 plus, they basically use the flu zone high dose. They say especially if you're taking a statin, there's some question if there may be some immunomodulation by the statin or if it's just a compounder, but probably better to get it if you're on it. And there's a slightly increased mild to moderate local reaction, but the serious adverse rate is similar, so it's more of a mild increase than a severe increase. And then the adjuvant vaccine isn't recommended by the ACIP, but the data are still coming, but right now no one's showed efficacy in older adults, so that's why they're not recommending it yet, but they may in the future. And then it's okay to give it if they have a chronic neurologic disease like multiple sclerosis, just as an FYI. And then the egg allergy thing. So this has been kind of a big thing, right? It's on our form. Do you have an egg allergy? Have you ever responded? And the question is, does that matter? The short answer is no, it doesn't. The current flu vaccines and all of the organizations, whether it's the allergy groups, the immunization folks, pediatrics, they've all said there's so little albumin or ovalbumin in the vaccine that you can just treat people with egg allergy like regular people. You don't have to treat them any differently. Basically, there are no serious reactions less than 0.7 micrograms of ovalbumin, and most of them have like 0.0 something. It's very low. You don't need to do skin testing for egg allergy. The only reason to do that is if they have an allergy to the flu vaccine. Basically, if they're over 6 months, treat them like they don't have an egg allergy. You always have to be prepared for anaphylaxis. That's true with any vaccine, but you don't have to do anything special beyond what you would normally do for a vaccine. Observe the way you would normally observe. You don't have to do anything special. So this is just a quick list. I think the big thing was this column here, which shows how much of albumin content there is. I filled in here, I pulled this off the manufacturer label. It says less than 0.05, and as I mentioned, the cutoff is 0.7 for, under that you don't have a reaction. It's less than 0.05 for the standard, quadrivalent, and then it's pretty similar for all the other ones. So that's where that's coming from. So it's going to be a bit of a fight with people where they say I have an egg allergy, but these are what they're recommending. So when do you give it? So do it by October ideally, so before the flu season starts, and it takes a couple weeks to become effective. It's okay to do it with a minor respiratory illness with or without fever. So fever isn't necessarily contraindication. The question is if they're really sick. So you should delay it if they're moderately to severely ill. Really more so to avoid confusion. Is it vaccine that's doing this, or is it just because they're sick? Then watch out for travel to the tropics. So all year that can be a problem, and also cruise ships all year, northern and southern hemispheres, can have various flu outbreaks, so watch out for that too. I mentioned there's no live attenuated virus this season. Even when it was approved, you shouldn't give it if they have a URI because it might actually prevent adequate viral replication, like nasal congestion interfering or interferon preventing replication. You can't give it right now anyway, but even if you could, you shouldn't do it in those people. Give it in the deltoid ideally, and it's okay to give it with other vaccines. The only limit is with live vaccines, either give it at the same time or 4 weeks later. So who gets priority on these vaccines? So we're always running out. We're out in our clinic right now. I mean, this happens all the time. So who gets the vaccine? So people at increased risk. We talked about these groups, the extremes of age, pregnant, immunocompromised, chronic disease, and children and adolescents on aspirin, Native Americans, Alaskans, obesity, morbid, and then the nursing home folks. And also healthcare workers, basically all the major societies recommend it. So the question is, what does this actually do? I mean, obviously you want to get it so you don't want to get infected or pass it to your patients, but it is pretty common. Somewhere between 25 and 80% of healthcare workers get it. And getting the flu vaccine reduced absenteeism by 28%. So that's a pretty significant result. Hopefully fewer days you're missing work, and presumably that's because you're not feeling bad, not just because you're coming to work when you're sick, which you shouldn't do. The household contacts of high-risk patients, basically the only limit is don't do the live vaccine, which again isn't approved this season anyway, but if it were, there's a 7-day limit where if you're getting the live vaccine, you can't be around someone who is severely immunocompromised for the next 7 days. That's a change from just plain immunocompromised. If someone's on something mild, it's not a big deal. It's for the people that are severely immunocompromised that have environmental restrictions. So what are the benefits? So annual vaccination reduces mortality by 41% from the flu. That's pretty good. And that's what I tell folks is, you're less likely to die of the flu if you get the vaccine. That's the reason we give it. There's a better benefit with regular vaccinations. So this is the other piece, is getting it once is nowhere near as good as getting it multiple times. For people who had been vaccinated previously, there was a 75% mortality reduction, but it was only 9% for those getting it for the first time. So the benefit is better for getting it every year. If someone asks, why do I need to get this every year? This is why, is it works better the more you get it. There's also variable antigenic match. This is that guesswork part. They only matched it, 5% in 2004-05, but it was 91% in 2006-07. That translated to something like a 5-fold effectiveness increase. And part of that is that the folks that have gotten it multiple times are still having a good boost. Older adults, there are varying study results on the mortality benefit, but it does seem to show that the high dose will reduce infection rate and hospitalization, so they should definitely still get it. As far as giving it with the pneumococcal vaccine, there's a nice cohort study that showed reduced hazard ratios of death, pneumonia, stroke, acute MI, and fewer coronary and intensive care admissions. So it's a pretty good set of things you can do with one shot. As far as adverse reactions, so arm soreness is the most common problem, and Guillain-Barré is sometimes associated, but it's somewhere between 1 and 2 per million. But that risk is several times lower than the risk from getting the flu. So it's all a matter of risk, right? There's always a chance you could get Guillain-Barré. You could get it from the flu vaccine, but it's more likely to get it from the flu, so you should get the flu vaccine. That can be challenging for patients to deal with sometimes, but they're still better getting it. Then there's also this IgE hypersensitivity. There's this more unusually described ocular respiratory syndrome that could happen. It tends to happen within 24 hours where you get this. Generally, it's mild symptoms, but it's bilateral conjunctivitis and facial edema and maybe some cough wheezing. It's been less common since they cleaned up the vaccine a little bit, but it can still happen sometimes. It's usually not too bad. For the high dose, like I mentioned, more likely to have these mild to moderate local reactions. They also may have more GI complaints, particularly vomiting. So watch out for that. The intradermal, more site reactions, but actually not more pain. It was just the sort of visual and the swelling, but not pain. However, the needle-free one with the air gun did have more pain. So I guess if you're going to do one, if they're willing to do the intradermal, but they don't want to do the regular needle, maybe go with that if they're worried about pain. And don't give them flu vaccine if they have anaphylaxis. Send them to allergy. It's not that they can't get it. The question is, what are they allergic to? Is it, the ovalbumin? Trick question, probably not, because there's almost none in there. Is it, some component of that vaccine and getting, say, the cellular vaccine, the recombinant vaccine is going to be a better choice? That's for them to decide. We don't do that. If the live attenuative were approved again, which again, not this season, you don't give it to people who are immunocompromised. Don't give it to pregnant women. Don't give it to people who've had flu antiviral meds in the last 48 hours, because that'd be counterproductive. Only 18 to age 50. And people who have close contact with immunocompromised folks who require a protective environment in the next 7 days. And also asthma patients may have more wheezing, so be careful about that too. And then Guillain-Barré, like we talked about, 1 to 2 million per, it's lower than from flu. And I think that probably the trickiest part is, what about someone who had Guillain-Barré, but now you're asking, should they get a flu shot? So they have looked at this. Obviously, it's not a randomized controlled trial, but they have looked at this. And in a couple different studies, they didn't focus on people who had Guillain-Barré after the flu shot. It was just people who had Guillain-Barré. But people who had it previously, the flu shot did not seem to increase their chance of getting Guillain-Barré again, for whatever that's worth. It seems like probably it's the same as in the population where, yes, there's a risk. That risk is lower than getting it from flu, so you're still better off getting the flu shot. But honestly, if you had someone who got Guillain-Barré after getting the flu shot, I would be cautious, but the general recommendation is just that you should think about it. It doesn't say not to do it. And they should still vaccinate if you can. So giving reduced doses. So we're probably not going to do this too much. But the question is, if you're running low, can you split up the doses and get more doses out of your stock? So the question is, will this work well? When they look at it, there are differences in different populations. In particular, in women age 18 to 49, they had like equal or higher titers than men who got the full dose when they got a half dose. So if they got the 7.5 instead of 15. Now their geometric mean titers were slightly less, and people 50 to 64 had unacceptably low titers, so that was no good. Okay. So basically, you could give a half dose in women 18-49 who aren't pregnant, don't have other problems, but probably we're not going to do that. So, key point. Flu's common, particularly in season. It takes 2 days to incubate, shed for 5 days. Fever and cough are the best symptoms, but think about headache, myalgia, malaise, and chills, especially in older folks. Start with a rapid screen, because that's what we have in the office. And like I said, our test is good and not fully accounted for by their models, but you may need to confirm, depending on prevalence, use RT-PCR if you need to, or culture, depending on your preference. There's a lower threshold for treatment in those high-risk groups we talked about, and basically treat with oseltamivir or zanamivir for 5 days, again, depending on the population for zanamivir. Vaccinate if they're older than 6 months. Do the quadrivalent if you can. Give the high dose if they're over 65. And there are other options if they have particular requirements. And take extra precautions for flu vaccine allergy, but not egg allergy. So back to those cases. 35-year-old African-American female who comes in for preventive care. What do you do for her? Give her the shot. You can do quadrivalent, or if she has a particular requirement because of allergy or other history, you can do one of those other ones. 45-year-old white male with morbid obesity, 72 hours of fever, cough, fatigue during the flu outbreak. You're thinking you might have flu, reasonably likely because of the outbreak. Go ahead and treat him even though it's been more than 72 hours, but only do the Tamiflu because of his asthma. You don't want to give him the zanamivir. 67-year-old Alaskan native who comes in for preventive care with mild fever and sinus congestion. He's not too sick. You're okay to go ahead and give the high dose with the age greater than 65. And then 28-year-old who's pregnant, 14th week of pregnancy. Do you want to give the vaccine? Definitely. Tdap you do at a certain stage of pregnancy for fetal protection, but the flu shot basically give is whenever you can as is appropriate. And that's about it. So any questions?
open this up here.
It was interesting about the mortality rates. I didn't know that was like the sequential vaccinations improving mortality.
Yeah, that's a big difference.
I think it's good to talk to patients about it because for whatever reason, I feel like people reject the flu shot more than anything else. And they just have whatever phobia it is. I don't know why.
Thanks, Aaron. That was a great talk. I just had a quick question. You know, people often come in and ask, you know, in September, is it too early to get the flu shot? You kind of mentioned that we should try and get everyone vaccinated by October. So did you come across any of the data looking at efficacy over longer periods of time or lack of efficacy if you received the flu shot in September versus at a later time?
Yeah, so there was some thought about that. So first of all, it takes 2 weeks to get ready, and then it seems like there's this sort of peak effectiveness for those 3 months after that period. And so you ideally want to line that up with the peak flu season, which is usually December, January, February. So that's where that like end of October time is just about right. So we're, I guess, about a month out from that, but that would, you know, be about right where you're fully immune heading into December, and then hopefully you're right about there. So should you get it in August when it's first available? You know, all things being equal, if you're not in a healthcare setting where you're going to be exposed early like we are, it probably is better to get it in October for peak benefit in flu season. But the honest truth is, it's better to get vaccinated. So if they're going to do it in August but not another time, go ahead and get it. But if they're trying to time it, as long as they're not going to be exposed early like we are, probably a month or two after that, it's better.
Are there any other questions or comments? Okay, well, thank you very much, Aaron. That was a great talk.
Thanks, guys.